Okay, looks like we are live and it's 11:30, so let's go ahead and get started. All right. So thank you for joining me today. My name is Hiva. If you haven't joined one of my webinars before, I'm a nurse practitioner with Archer Review, and today we're going to talk about EKGs. So today is our EKG review. You probably already know that because you're here, you registered for it. So I'm glad that you're joining me today. I will go over this slide at the end of the lecture as well, so don't feel like you have to memorize everything on it now, but we'll talk at the end about our Q bank and our on-demand services and our awesome 3-day live review that's coming up in September. And of course, you should always follow us on social, but I'm going to get started on our lecture today, and then we'll go over that slide at the end again. So again, as always, I like to keep these lectures pretty interactive. So get your chat box open. We have our awesome Rachel Ward on our chat box helping us answer any questions as we're going through. I'm also going to ask you a couple of practice questions as we're going through this lecture so that it really helps solidify some of these concepts for you. So we're not just lecturing at you, but you're more able to engage and ask your questions as we go along. So feel free to take a minute and open that chat box and we'll get started. So I always like to start this lecture by going over some EKG basics. That way we know we're all on the same page and we know that we kind of all understand what we're talking about, right? Because we're not just memorizing, we're going to really understand how to interpret these EKG strips, how to interpret these arrhythmias. The first thing I always like to start off by talking about is EKG placement. And this might seem like, well, why are we talking about EKG placement when I'm a nurse practitioner, my medical assistant, or my nurse is going to get the EKG for me? I just have to focus on the report. EKG placement is really important because you have to understand what that lead placement is doing for your report, right? So we'll talk about that during this lecture. But getting familiar with the placement of the EKG and playing around with it in a clinic, especially if you're still a nurse or if you have the opportunity to do that in your clinicals, is really important because there will be a time where you're looking at that 12-lead EKG report and it won't make sense. And the first thing you should think of is, well, is this an EKG placement lead issue? And I learned that the hard way. So always make sure you understand what's going on. So we have 6 chest leads. We have V1 through V6, and then we have 4 limb leads, which you can see on this illustration. And we'll talk about that a little bit as we're going through this lecture. So a little bit about the electrical conduction system. So remember, as we're talking about this, it's going to make sense for you because we want to interpret that and how that looks on that EKG strip. Remember, the electrical conduction system starts in that SA node in that right atria. That is your heart's pacemaker. So you have 2 pacemakers. You have one in that right atria, and then you have another one in the ventricle. That's your backup pacemaker. Your main one is that SA node, and so that starts to fire that electrical impulse. That impulse travels across the right and the left atria, slows down a little bit right before it reaches that AV node to allow for that atrial contraction, and then it travels through that AV node down that bundle of His and through the left, it splits off into that left and right bundle branch blocks and allows for that ventricular contraction. So that is the basic concept for your electrical conduction system. It goes around in a loop like that. In a normal adult, the heart rate's going to be between 60 to 100. And what that's basically telling you is that that SA node is firing 1 beat every second. And if that SA node fails, then you have your ventricular rate, and that's a little bit slower. And so it gets bypassed by that AV node, but that's about 30 beats per minute. So that's about 1 beat every 2 seconds. So if that fails, we get into those ventricular rates. And we'll talk about that when we're talking about the difference between atrial arrhythmias and ventricular arrhythmias. But know that that SA node is your pacemaker, and normal is between 60 to 100 beats per minute. So let's look at it from another way. What does that look like on your EKG? So as we talked about, that SA node fires that electrical impulse, and so that travels over the right and the left atria. And so you're going to see that contraction, that atrial contraction on your P wave. So remember the parts of your EKG, you have your P wave, you have your QRS complex, and then you have your T wave. And so that P wave is that atrial contraction. You have your QRS contract complex, and that's going to be your ventricular contraction. And then your T wave is that ventricular relaxation, which is really important. So that's why we look at to see if there's any inversion as well, because we want to make sure that those ventricles are relaxing and filling again, right? So that's what you're seeing in those parts of the EKG. So let's look at it another way. Let's look at it on that EKG strip, which is usually printed on this beautiful graph paper. If you are, as old as I am, you went to school with actual graph paper where you had to do math on actual graph paper, that's what this is printed on. So this is printed on graph paper, and those little boxes actually mean something. So that tiny little box is about 0.04 seconds. And so if you count it out, you see that there are 5 of those tiny little boxes within these bigger, thicker walls. So 4 times 0.04 times 5 is 0.2. So that's about 0.2 seconds long. And why does that matter? You're saying, like, why do I care about 0.2 seconds? Well, one, it's good to realize that EKGs are really just a short glimpse of the electrical conduction system. So if you have a patient coming in complaining of, occasionally I get short of breath, occasionally this happens, and it's not happening in your office in that moment, you get the EKG, it's normal, you shouldn't dismiss that. You want to still investigate it, because this is just a very brief window of the patient's electrical conduction system. If you're not seeing it in that brief window, it doesn't mean it's not happening. You probably want to follow up with something more like a longer term Holter monitor or vet monitor, just to see if something's happening over a longer span, like 7 to 14 days. And sometimes you can go up to 30 days as well. But anyways, so these little blocks mean something. And so that's also really helpful when you're trying to interpret your EKG arrhythmias, because you want to see your intervals, if they're normal or not. And that'll tell you if it's an atrial or ventricular arrhythmia. It'll tell you what type it is. So that's going to be really helpful to get used to looking at your EKGs with those little blocks. So again, we have our P wave, we have our QRS complex, we have our T wave. We also have our PR interval. So that's going to be from the beginning of the P to the beginning of that QRS complex. We have our QRS complex, of course, that's right here. That's the QRS. And then we have our ST segment, which is between the S to the beginning of the T. And then we have our QT interval, which is from the Q to the end of the T. So those are things that you should get familiar with. And then basically what I like to do is I like to look at the boxes instead of counting the seconds. I like to know my PR interval normal is between 0.12 and 0.2. So that's about 3 to 5 boxes. And so if you look here, you see that that's beautifully within that 3.5 boxes right there. And then your QRS normal is going to be less than 0.12. So that's less than 3 boxes. So you see how you can see that easily when you're looking at those smaller boxes. So getting familiar with those boxes can be really helpful. One other part of the EKG I want to bring to your attention, and this goes back to that lead placement, is when you get an upward deflection like that, that is the electrical impulse of the heart, or the electrical impulse moving towards the electrode. So when you get this upward deflection, that's that ventricular contraction. And again, that upward deflection is moving towards the electrode. That downward deflection is moving away from the electrode. So that's going to be really helpful too, because if you're seeing things all flipped around, that's when you want to definitely check that lead placement as well. So that's going to be helpful. Okay, so with all that said, those were all the basics. How do we actually start to interpret some of these rhythms, right? Always come up with your own systematic approach. This is what I like to do. This is how I got started when I started teaching myself how to read 12 leads. But it really is helpful not only to build confidence, so you know that you're doing it the same way each time, but it also helps you feel like, okay, I didn't miss anything because I'm doing it the same way each time. Did I look at the general impression? Did I check the rate and the rhythm? Did I look at the QRS complex? Did I look for any hypertrophy? Did I look for any signs of ischemia or infarct? Did that patient, are they coming into your office saying they have shortness of breath? Are you looking for any signs of ischemia, infarct, chest pain? You want to definitely make sure you're not missing the ischemia or infarct, right? That's what we want to prevent. So coming up with a systematic approach is going to be really helpful to help build your confidence and make sure you don't miss any steps. And so that's how we're going to look at the rhythms moving forward in this lecture. So let's look at a normal sinus rhythm. What makes it normal? First, we look at the general impressions. I like to see, do I have all of my parts, right? Is there a P for every QRS, T wave? And what I caution you is to make sure you're not just looking at one and being like, okay, that one has a P, QRS, and T wave, great. So you want to look at each one, and we'll talk about that as we look at other rhythms because it does matter looking at each one. And you want to look at a 6-second strip, right? And so if you counted all those tiny little boxes, so there's going to be about 15 from this point to that point. 15 times 0.2 is about 3 seconds. So this is another 3 seconds. You always want to be looking at a 6-second strip, okay? That's going to be really helpful. And so you want to look at each one and make sure you have a P for every QRS T wave, P for every QRS T wave. And general impressions, are you seeing any inversions? Are you seeing anything funky, any hypertrophy? Are you seeing any ST segment elevation or depression? Is there anything funky going on? Just your general impressions. And now we're going to start looking at our rate. So let's calculate our rate. And there are different ways to do it. This is the way I like to do it, but you want to count your R to R. That's going to be really helpful. So it's not just counting one R. That's not your one. Your one's going to be one R to the next R. So here we do 1, 2, 3, 4, 5, 6, 7, 8. So you have 8 R to R's here. You're going to multiply that by 10. And so the rate of this is 80. If you were to count each R, you would count 9 R's and you would say rate is 90, and that'd be incorrect. So you definitely want to make sure you want to count that R to R to get the right rate. And then you want to take a look at the PR interval. So again, this is kind of a little bit small on your screen, but when you're looking at it, you can see it very clearly. Is the PR interval within 3 to 5 boxes, or is it prolonged? Then you want to look at each PR interval. Don't skip out on that. Then you want to look at your QRS complex. Is it narrow or wide? So narrow means less than 0.12, less than 3 boxes. So you're going to look at each QRS complex, or is it wide? Is it more than 3 boxes? That should tell you that it's a ventricular arrhythmia. And then we talked about that rate, and so it's regular. You want to look at the QT interval as well. That's a different calculation that gets a little bit more complex. We will skip that for today. But basically looking at this is a normal sinus rhythm. So the rate is normal and all the intervals are normal as well. So who can tell me why we look at the QT interval and what we worry about with a prolonged QT? You might see that come up on your boards. What do you guys think? I know I kind of chatted a lot, so if you need some time to get your chat box open, that's okay. But what do you guys think? And remember, there are no wrong answers. I rather you get it wrong now and get it right on the exam. But you might look at the QT interval for what? What are we trying to prevent? So you want to look to see if you need to make any medication changes. That could be a good guess. Yes, so that's exactly right. So torsades is what I was trying to get at. Very good. So with that prolonged QT, you might see a question like that come up on the boards because they really want to make sure that you know that it can lead to ventricular tachycardia, and torsades de pointes is a type of ventricular tachycardia, which is a dangerous arrhythmia. So with a prolonged QT, you definitely want to make sure that you're looking at patient's medication. Are they on medication that's prolonging that QT? Do they need to be treated for their prolonged QT? Do they need to be on a beta blocker so that we can help prevent that ventricular arrhythmia? So that's exactly right. Very good. So now let's talk about the QRS complex. This gets, this sometimes gets people a little intimidated and bogged down. I'm going to do a general overview of QRS access. You're going to get more familiar with it as you're reading more and more 12-lead EKGs. And again, for your boards, you just really need to know high level, very common arrhythmias. They're not going to get in the nitty-gritty of the QRS axis, but I didn't want to not talk about this today before moving on to the next things. But QRS axis basically tells you the direction that the electricity is moving in, or that electrical conduction system is moving in your heart. And remember, it's always going to be slightly deviated to the left because your apex, the apex of the heart, is always slightly pointing to the left. So a normal axis is going to be between -30 and 90. And so you're looking at these leads to determine if it's normal or if it's abnormal, if you have a left axis or right axis deviation, or in some cases, extreme axis deviation, which I've never seen. And so in that case, you definitely want to make sure you've checked those lead placements. Those limb leads sometimes get flipped and then it looks like an extreme axis deviation. So you have to go back and get that EKG report printed again. But basically, what we want to see is that it's falling within that -30 to +90, right? So you want to see upward deflection in these leads. And then if you see a upward deflection in these leads, so anywhere above that -30 to that -90 is going to be that left axis deviation. And then anywhere above that 90 to 180, it's going to be a right axis deviation. And so why is this important? Because you can then really tell, is there some underlying damage to the structure of the heart? So in a left axis deviation, you might see also some hypertrophy. That patient might be an uncontrolled hypertensive patient, and maybe the muscle of that heart, especially that left ventricular side, has gotten really thick. And so when it's thicker, it takes longer for that electrical conduction to move through those cardiac muscles. And so you're going to see more deviation of that axis to that side, right? So it's going to move a little bit slower towards that side. Now, the opposite is true for infarct. So if you have an infarct on that left side, you might see some right axis deviation because there's been some infarct on that right side, left side. Because remember, if those muscle cells are dead, if those cardiac muscle cells are dead, there's not going to be any electrical activity going through it. So it's going to be more of a right axis deviation. And I definitely would be a little bit more worried about right axis deviation than left axis deviation. Certainly left axis is more common. But basically, the QRS axis can help determine the direction that the electrical conduction is moving in, and that's going to be helpful to determine, do I need to send this patient to cardiology for further evaluation? Maybe they need to do an echocardiogram to look at those cardiac muscles, the structure of the heart, to see if there have been any modeling due to chronic disease that's been uncontrolled or not treated. So you definitely want to look at that QRS axis once you get a little bit more comfortable with reading your 12 leads. But I'll leave it at that today. I know sometimes it gets a little bit overwhelming. And then same thing with hypertrophy. I'm not going to get too in depth into the nitty-gritty of hypertrophy because I don't want to overwhelm you. But what I do want you to know is that there are different types of hypertrophy. There's atrial enlargement. So sometimes if you have some underlying structural, maybe some valve issues, you can get some that left atrium can get really floppy, and then that can lead to AFib. That could be the underlying cause of that patient's atrial fibrillation. But you can definitely have atrial enlargement on both the right and the left side. And then you can also have ventricular enlargement or hypertrophy, both on the left and the right side. And that left side is going to be more common. So you'll see that left ventricular hypertrophy more commonly in clinical practice. And then the big ones you don't want to miss are the ischemia, and certainly we want to prevent the infarct. So recognizing what we call that 3I triad is going to be really important. Remember, ischemia is indicating reduced blood flow to that part of the cardiac muscles, and we're going to see that in that T-wave inversion. I remember this was early in my practice. I had a patient come in and he was overweight and he was complaining of shortness of breath, but it wasn't like obvious shortness of breath. Where I was practicing at the time, there were a lot of hills, and he was saying that he noticed that he was requiring more effort for him to be walking up the hill. And so, of course, with him being overweight. He had gotten dismissed a lot. So he was pretty upset in my office and pretty tearful. So making sure we listen to our patients is really important, because when I got that EKG on him, I in fact saw that T wave inversion. So I knew that there was some ischemia happening to his heart. And turned out that he did have a large central PE. So again, listening, taking a thorough history, and then looking for any signs of acute ischemia or acute infarct is going to be really important in preventing the necrosis of those cardiac muscles. So again, T wave inversion can indicate ischemia. If we get an ST elevation, that can indicate injury to those cardiac muscles. That could be either acute or a recent infarct. And then ST depression is always going to be indicative of an infarct. So definitely want to watch for that. And also a wide and deep Q wave is going to be indicative of an infarct. And again, we're really trying to prevent those infarcts. So catching all of these early and intervening early is going to be really important. Okay, so let's jump into our arrhythmias. Again, I just gave you the basic ones. I didn't want to get too deep and overwhelm you guys. So these are going to be the basic arrhythmias that you really need to know for both your boards and your clinical practice, and just something, a good starting launching point for you as you start to get more and more comfortable with EKGs. So sinus bradycardia. So what defines sinus bradycardia? It's a resting heart rate of less than 60 beats per minute in an adult. Remember, normal beats per minute or normal heart rate in an adult is between 60 to 100. So sinus bradycardia is when it's less than 60. And so how do we know that? Let's look at this in our systematic approach, right? So first, we're going to look for general impressions. Are all our parts there? So we see that there's a P for every QRS, there's a T wave. So looking at generally everything seems to be there. Now let's calculate the rate. So we're going to go R to R. We're going to go 1, 2, 3, 4. When you get a little bit more comfortable, you can see that that's about 4.5. So multiply that by 10. This rate is about 45. So that's definitely less than 60. So right there, we know the rate is not normal. Now let's look at the PR interval, and you're going to calculate that. And you're going to see that it's between 3 to 5 boxes. So the PR interval is normal. And then you're going to look at that QRS complex. Is it narrow? Is it wide? And you're going to look at each one. And in fact, it's less than 3 on each one. So everything's looking good except for that rate. So this is classic sinus bradycardia. Now with bradycardia, it can be normal in some patients, especially our athletic patients who are really in good shape. This could be normal for them, but you always do want to investigate sinus bradycardia. So asking really thorough history questions. Is this something that's normal for them? Is this new? Are they feeling symptomatic? Is going to be really important, because we want to make sure if there's an underlying cause that needs to be fixed, we do fix it. But most of the time, this is normal for the patient and it doesn't need fixing. But we definitely want to make sure that we catch anything that does need to be fixed and prevent it from turning into a more dangerous arrhythmia. So now sinus tachycardia. So this, on the flip side, it's defined as a resting heart rate above that 100. So how do we know this is sinus tachycardia and not a ventricular tachycardia? Can anybody tell me that? I have to keep my chat box open too as I'm talking. So you're looking at the P wave, that's good. But what was one thing I said about the QRS complex where we know whether it's a supraventricular or a ventricular arrhythmia? Can anybody? Well, I guess I gave you the answer, but that was a very good guess. I appreciate the participation. So that's exactly right. It's the QRS complex. And here the QRS complex is narrow. So that tells us that it's a sinus tachycardia and it's not a ventricular arrhythmia. So if we're doing our systematic approach, let's take a look. We're going to, our general impressions, there's a P, QRS, T wave, P, QRS, T wave, and we see that with each one if we go through. And then we're going to count our rate. So we're going to go from R to R, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 times 10 is 130. And that's certainly over 100 and still less than 150, because if you get over 150, that's going to be SVT. That's a different arrhythmia. So it's still less than 150, but over 100. So this is a faster heart rate. So we know that that's abnormal. And then we're going to look at that PR interval, and that is normal on all the PR intervals. So it's between that 3 to 5 boxes. Now we're going to look at our QRS complex, and this is what tells us that it's sinus tachycardia. It's still narrow. So it's still less than those 3 boxes. So that's normal as well. So the only thing that's irregular is that rate. And so we know this is sinus tachycardia. But great guess. And so things that can cause this, certainly drugs, illness, fever, pain, exercise, caffeine, but you definitely want to investigate why that patient is sinus tachycardic and fix the underlying cause. Sometimes it may not need fixing, like you may have a diabetic patient who is chronically coming in with high blood sugars, and they're going to be slightly tachycardic at every visit, just a little bit over 100. But my argument would be that that also needs fixing because we need to get better blood sugar controls, right, to get their heart rate down. And then sometimes it may need very obvious fixing. Like I had a patient one time come in who was being really overtreated with her thyroid medication by a different provider, and she was not being compliant with doing regular follow-ups and getting her levels checked and taking too much medication. So definitely want to investigate sinus tachycardia. It's not normal. Sometimes, again, it may not need fixing if it's the patient is fighting off an infection, but you don't want to miss the big one. So if it's sinus tachycardia with hypotension and a fever, then that is an infection that you would be worried about, because we'd be more worried about sepsis, and that patient needs to go to the hospital. But if it's a common cold and you've ruled out a secondary bacterial infection, you might see a little bit more of a rapid heart rate in that patient. But again, takeaway always does need some investigation to see if there is an underlying cause that we need to address to fix. Okay, so atrial fibrillation, this is going to be the most common arrhythmia that you see in your outpatient patient population. And so this one you're going to get really familiar with. Some patients will come in really symptomatic. Some patients will not be symptomatic at all. And then some patients will either be in it persistently, meaning they're always in AFib, and some patients may have paroxysmal atrial fibrillation, meaning that go in and out of atrial fibrillation. And typically those patients are the ones that are more symptomatic because they can really feel the difference. It does increase, the risk increases with aging and also post-cardiac surgery. But with atrial fibrillation, what is the biggest thing to remember with atrial fibrillation? And this might come up on your boards, but what do we want to make sure that a patient with atrial fibrillation is on? And it's on the slide. But what do you guys think? Very good. Yes, you always want to make sure this patient is anticoagulated. And why is that? It's because the turbulence in that blood flow can cause increased risk for embolism. So you always want to make sure this patient is anticoagulated. And you also want to make sure you're pacing this patient until they've been evaluated by cardiology. Cardiology might determine that the patient is a candidate for cardioversion or ablation, or they might say, okay, you can just keep them rate controlled and on a beta blocker, or just anticoagulated, and that should be fine. So this patient always definitely needs to be evaluated by cardiology, but for you as primary care, you need to get them started on the anticoagulation and rate control them until they can get in to see cardiology. And the classic way we know this is atrial fibrillation is those P waves, right? They're really floppy. There's no rhyme or reason to these P waves. There's no PR interval because there's no real P wave. And then the QRS is staying narrow. So we know this is a supraventricular, so above that AV node arrhythmia. And it's all really irregular. So you can see. And what I would tell you is if you have a patient, especially a really stable patient who comes into your clinic and they've been on anticoagulants and rate controlled and followed by cardiology for a long time, you're just seeing them for a physical, and they have persistent atrial fibrillation, I always want you to feel their pulse, especially while you're listening to their heart. So if you can practice that, you'll really feel the difference between someone in atrial fibrillation and someone not in atrial fibrillation. And it's a nice skill to have, because then sometimes you might catch it incidentally on just checking a patient's pulse before you even see it on an EKG. So it's definitely a really nice skill entitled to have. And so these patients, we definitely want to make sure that we're also assessing their stroke risk, but getting them over to cardiology to get them further evaluated is going to be really important. So now let's look at atrial flutter. So how is this different from atrial fibrillation? Can anybody tell me that? So how is atrial flutter different from atrial fibrillation? And Sophia, we'll get to, before we jump into that, so I just want to answer Sophia's question in the chat. So which anticoagulants do we use for AFib? So that can also be determined on a case-by-case basis with that patient. You could either do Coumadin, warfarin, or some of the newer medications, depending on that patient's particular case. So good question there. Awesome job. But how do we know this is atrial flutter and not atrial fibrillation? Can anybody answer that? Okay, you guys got it. So it's that sawtooth look to that P wave. You see how all the P waves kind of have this very classic pattern. They all look different. So in atrial fibrillation, there was really no rhyme or reason to that P wave. In an atrial flutter, you see a very classic pattern and it repeats each time. The reason for that is because in atrial flutter, you have multiple ectopic stimuli, right? So it's coming from different parts of the atrium. And so it's causing kind of a not consistent look on the EKG strip. But at atrial flutter, you just have one atrial ectopic foci and it's firing rapidly. So it's coming from one area of that atria and it's just firing rapidly. So you see that consistent look across the P wave. So that's what makes it different. That's very good. Some patients may be symptomatic, some patients may be asymptomatic, can really range from anything from shortness of breath to having syncopal episodes. But these patients may definitely require some pacing and rate control as well. So you want to get them over to cardiology as well to evaluate what's causing the underlying atrial flutter and treat it. I feel like atrial flutter doesn't get as much attention as atrial fibrillation because it's not as common as AFib. Again, AFib is the most common that you're going to see in your outpatient clinical setting, but definitely something that you will see and needs to be evaluated by cardiology. Okay, so let's do a practice question. So Sophia, this will help you as well. So how might you see the anticoagulation questions come up on the boards? This might be an example of one. So a 51-year-old patient is taking warfarin Coumadin for atrial fibrillation, and her INR this morning is 2.5. Which of the following is appropriate? So is it A, B, C, or D? And so they definitely want you to be able to manage Coumadin even when that patient is being seen by cardiology. Oftentimes, you're going to get patients coming in with labs that they've done for you, as well as labs that they've done for cardiology. They haven't seen cardiology yet because it's hard to get in to see them. So you want to make sure you're talking to them about their INR and their Coumadin, and you're making dose adjustments as necessary. So this is something that you can also get comfortable with, knowing the therapeutic range for Coumadin therapy. So what do we think? Let me open up my chat again. Okay, so you guys are rock stars. So D is exactly right. So the therapeutic range for this INR is between 2 to 3, and so a 2.5 is right within that therapeutic range, so you don't have to make any dose adjustments at all. Awesome job, you guys. Great participation. Okay, so now let's jump into our ventricular arrhythmias. We're going to talk about PVCs, or premature ventricular contractions. I don't know why, but these seem to be my favorite. And so I think it's because, they're totally benign and really common. And oftentimes patients will get really freaked out by it and they'll say, occasionally I feel like I have to catch my breath or take a deeper breath and then it goes away. What is that? And then you'll get an EKG and it'll be totally normal, but you can get that Holter on and they'll see like occasional PVCs and you can talk to them about that. And then sometimes you might actually incidentally find it on if you're getting like a baseline EKG on a patient and they're calm as a cucumber and they're just like, no, I feel great. And then you're just like, all right, that's just an incidental PVC that you happen to capture on the EKG strip, and you can just write that in your notes when you're signing off on that EKG report. So I really like them. They're pretty classical in their appearance with that wide QRS complex, because remember, it's a premature ventricular contraction. It bypasses the SA node and it just fires off a ventricle contraction outside of the loop, but the loop is continuing to go. So you see that early ventricular contraction kind of bypassing everything. So you see that extra wide and bizarre QRS is the way we call it, and there's no P wave for it because again, it's a ventricular rate. It's a premature ventricular rate, just like its name suggests. And like I said, these are pretty benign. You usually don't have to do anything about it unless you see a run of 3 or more of PVCs. Then we're actually worried about it's developing into a ventricular tachycardia. We technically 3 or more PVCs is categorized as ventricular tachycardia, which is a dangerous arrhythmia. So you want to make sure that you're not seeing a run of 3 or more, but otherwise you might see them incidentally or on the Holter monitor that you order. Again, incidentally, in cardiology, we'll be looking for that run as well. So ventricular tachycardia, so what makes this VTach? Again, what are we looking for in that QRS complex? Who knows? What do you guys think? It's on the slide, and I've said it a couple of times, but I'm going to give you guys a few minutes to think about it. So what makes this VTach? What makes this a ventricular tachycardia as opposed to a sinus arrhythmia? That's right. So it's a wide and bizarre QRS complex, right? So when you look at this, you're not seeing a P wave for a QRS, you're not seeing a T wave, you're just seeing a bunch of wide and bizarre ventricular rates, right? The QRS is just very wide and bizarre. So it's definitely well over those 3 small boxes. Again, there's no P wave, so there's no PR interval, and that rate is going to be really high. So it's going to be a ventricular rate. And so why do we worry about VTach? Why do you guys think? What's so dangerous about ventricular tachycardia? I know I'm asking some really hard questions, but why do you guys think? Why do you think ventricular tachycardia is really dangerous for the patient? So if you have a very fast ventricular contraction, what's happening with the blood? Are you allowing those ventricles to fill and get adequate cardiac output, blood out of the heart, or is it not giving the heart time to fill, right, to relax? Right? It's the latter. So ventricular tachycardia is really dangerous because of that poor cardiac output. So remember, we talked about looking for those prolonged QT intervals. It can lead to dangerous arrhythmias like VTach, ventricular tachycardia. So we definitely want to make sure we're asking our history questions. Have they had any episodes of syncope or pre-syncope? Have they had a family history of sudden death? What medications are they taking? We definitely want to make sure we're asking those questions, and VTach definitely needs to be intervened. So if that patient has a pulse, we're going to try to cardiovert them back into a normal sinus rhythm. If the pulse is absent, this is when our ACLS protocol is going to come in action to help save this patient's life. And so what we're trying to prevent is ventricular fibrillation. So here, this is a type of cardiac arrest. You see that those ventricles are just fibrillating. So they're not even contracting or relaxing. Cardiac output is really, really low. This is really dangerous. And so this is when your CPR comes in handy and you're really trying to save this patient's life. So VFib is what we're definitely trying to prevent. And so here you see there are no P waves, no PR interval because there's no P waves, no QRS interval, no rate. I mean, nothing's going on. There's just absolutely no very little cardiac output in this patient. So biggest takeaway, those ventricular arrhythmias, aside from PVCs, VTach, VFib, those are really dangerous and we need to intervene quickly. So when you think VTach, think very bad, right? All right, so now let's jump into our bundle branch blocks. So bundle branch blocks, I don't know, I guess PVCs aren't my favorite. I also like bundle branch blocks, but maybe I'm just silly. So bundle branch blocks, remember the impulse is starting in that SA node, it gets to that AV node, it travels down that bundle of His and then branches off into that right and left bundle branch and allows those ventricles to contract simultaneously. In a bundle branch block, you're getting a delay or a block in the impulse in one of those bundle branches, either the left or the right side. So they're not contracting simultaneously, they're contracting kind of asynchronously, and that's why you're seeing this funky little R, right? Usually you get that nice sharp R, and here you see a funky little R, and you're like, what is that? Well, that's a bundle branch block. And how do you know whether it's a left bundle or a right bundle branch block? Remember, we talked about lead placement. So those chest leads, V1 through V6. So I like to look at my chest leads to see where am I seeing that M. And if I'm seeing it in the left chest leads, if I'm seeing it more in V5 and V6, I know that's a left bundle branch block. If I'm seeing it more in my right chest lead, so V1 to V2, I see that M, I know that's a right bundle branch block. And it's really exciting when you get really comfortable with finding these in clinic for the first time. You're like, oh, I know the difference between a left and a right bundle branch block. But it's really fun to get really comfortable with this and start identifying them. I remember that feeling as a new grad and being like, oh, now I know what I'm looking at. Left bundle branch blocks are more common than right bundle branch blocks. Right bundle branch blocks are definitely a little bit more concerning, but either needs to be evaluated, but you do see patients more commonly with that left bundle branch block in those left chest leads. So now we're going to talk about first degree heart block. So when we're looking at this strip, if you're looking at it quickly, you might think this is normal sinus rhythm. So let's break it down. Why is it not? So you're checking for all the parts. There's a P for every QRS, a T wave. Okay. We looked at all that. So yes, all the parts are there. Now let's look at the rate. So 1, 2, 3, 4, 5, 6, maybe 6.5, but definitely between that 60 to 100. So it's a normal rate. Now we're going to look at that PR interval, and you'll see that it's well above those 5 small blocks, right? So the PR interval is prolonged. That's what we call prolonged. And you're going to look at each PR interval, and you'll see why on our next slide. But it's pretty consistent all the way through. And then you're going to look at your QRS complex, and it's still what we call narrow. So it's less than those 3 boxes. So here you can see that prolonged PR interval is the only thing that's off, and that's going to be your first degree heart block. These are generally not as concerning. Treatment's generally not required, but should still be investigated to make sure there's nothing underlying like electrolyte abnormalities or drugs or congenital heart defects that are causing it. Certainly in our pediatric population, if we find a first degree heart block, we want to send them over to pediatric cardiology to evaluate to make sure we're not looking at any congenital heart defects. Typically, those are caught a little bit earlier than probably when you're getting an EKG on that pediatric patient, but we want to make sure that we evaluate the underlying cause, but sometimes it is normal and there's no fix or no treatment required. Now, when we get into second degree heart blocks, it's a little different. So second degree heart block, we're going to talk about type 1 and type 2 today. So type 1's also called Mobitz 1 or Wenckebach. It goes by a couple different names. This is when you see a progression of that prolonged PR interval until one of the QRSs just drops off. And so that's why we look at each PR interval and we don't just look at one and say, okay, that's normal, right? So again, when we're looking at this, we're going to look at general impressions. Is there a P for every QRS, T wave? We're looking, all the parts are there except for here. Wait, where did that QRS and that T wave go? There's just a P. Then it picks back up and you're going to look again. And then it drops again. Now we're going to count the rate. 1, 2, 3, 4, 5. So the rate, so this is 5, 6. So the rate is typically normal, still within that 60 to 100. That's why it doesn't make it as dangerous as type 2. But then you're going to look at that PR interval, and that's going to be the telltale sign this is second degree type 1 or Wenckebach, because you get that prolonged PR until it drops. So that's what's going to be pretty classic for that type 1. And so oftentimes this happens post cardiac surgery. So that's why we keep patients overnight just to make sure they haven't developed a heart block, and we'll intervene if necessary. If the patient is asymptomatic, sometimes you don't need any treatment at all. But if they're symptomatic, this patient might need pacing. So that's going to be important. But this patient's more hemodynamically stable than type 2 just because that rate is normal in this patient. So type 2, the rate is generally less than 60. So that's why we worry about these patients. We definitely want to pace these patients and find out what's causing that underlying issue. And the other difference between type 1 and type 2 is you don't get that prolonged PR interval, but you still get the drop. So the difference is it's not prolonged. That PR interval is pretty fixed and it's typically normal, but then you do get that drop QRS, and that QRS still stays pretty narrow. And so if you count that rate, 1, 2, 3, 4, maybe 4.5. So that rate is definitely below 60, right? So we worry about this as being potentially life-threatening and can develop into something more risky like third-degree heart block. And so in third-degree heart block, this is when the SA node and that ventricular rate, they're just not talking to each other at all. So this is also known as complete heart block, and it's the most serious type of heart block. And that's basically due to that severe bradycardia. So if the AV node system is failing, it's not listening to the SA node and going by the pacemaker, then they're all doing their own thing, then you're going to have an issue with getting that cardiac output, right? So you're going to have poor cardiac output. So when you're looking at this, initially, you're going to look at the parts and you see, okay, there's a P wave for this QRS, there's a T wave, there's a P wave, but nothing else here. Here's a P wave, QRS, maybe T wave and a P wave, but nothing here. And then if you march it out, actually the P's are talking to each other, and it's pretty consistent interval between the P's. So they're talking to each other. They're on they're marching out to their own beat. And then the QRSs are also marching out to their own beat. So they're talking to each other too, but they're just not talking to each other, right? So the SA node is definitely not going through to that AV nodal system, and that AV nodal system is failing to follow the instructions of that SA node, and they're doing their own thing. So that PR interval is going to be variable. That QRS complex is still going to be less than 3, but it's not going to be wide, but we're still not talking to each other. So that's going to be pretty classic of this third-degree heart block. This is very high risk for progressing into cardiac arrest. So we definitely want to make sure we're temporary pacing these patients until we can get a permanent pacemaker placed. And we want to definitely have cardiology evaluate the underlying cause of these patients. And our goal is to prevent third-degree heart block, especially in that second-degree type 2 patient. So I know that was a lot, but we have a fun little poem. You've probably seen this before, but it's a nice way to remember the difference between all the heart blocks, especially when testing anxiety kicks in and you kind of get a little flustered. Just recite the poem to yourself. So if the R is far from the P, then you have a first degree. Remember, everything's normal except you have that prolonged PR interval. That's going to be your first degree heart block. Longer and longer drop, then you have a Wenckebach. Remember, Wenckebach is that second degree type 1. And so that PR interval is going to get longer and longer until you get that drop QRS. And then if some P's don't go through, then you have a Mobitz 2. So remember, in Mobitz 2, also known as second degree type 2, you're going to have the PR interval be fixed. So it's not getting longer, but then you still get that drop in that QRS. And then if P's and Q's disagree, then you have the third degree. So again, remember, your P's and your QRS are just not talking to each other. So they're marching to the beat of their own drum, right? And so we really worry about Mobitz 2 and third degree because the cardiac output is so low in these patients. We definitely want to make sure we intervene with temporary pacing and prevent any further complications like cardiac arrest in these patients. All right, so one last practice question, and I know you guys are all going to get this right because we talked about this today several times, and you guys have already told me this, but let's go over it one more time. QT prolongation predisposes an individual to what arrhythmia? Is A, torsades y puentes, B, sinus arrhythmia, C, atrial fibrillation, or D, third degree heart block? What do you guys think? All right, I'm seeing the answers coming in. Good job, Sophia. Come on, you guys. I want to see some more participation. I know you got this. All right, that's right. I knew you guys were going to get this right. So it's torsades, which is a type of ventricular tachycardia. So you definitely, again, want to look at that QT interval. You might see that pop up on the boards too. They want to make sure that you're also checking to make sure you don't need to take patients off certain medications that are prolonging their QT. You're also sending them to the right clinicians, cardiology to evaluate to make sure if they need to be on a beta blocker, are they symptomatic, not symptomatic, but we want to definitely prevent getting into some of those more dangerous arrhythmias like ventricular tachycardia, and torsades is a type of ventricular tachycardia. So awesome job. So I want you to take a picture of this page, and we do have a little bit of time, so I was going to try a little experiment with you guys today, but these are some resources that I found really helpful when I was entering clinical practice and when I was practicing for my board. So this is an EKG simulator. It's free, and there's a learn option and a game option, which I'll try to show you in just a second, but it's really fun way to practice learning your EKGs, and it's not letting me do it to copy, but let me see if I can show you what I'm talking about. But I like it because there's a learn version and there's also a game version where you could test yourself. And so let's see if it'll let me do it this way. skillstat.com/tools/ECG. Is it simulation or simulator? Take me there. All right, let's just do skillstat.com. There we go, EKG simulator. So if you type in that full URL that I put for you, there's practice and play. Let's begin. Oh. This looks a little different. Let's see. But either way, it's a free resource, and I wanted to show you what it looked like in the game. Oh, here we go. So this is the game and the learn version. So you guys should all be able to see this screen, hopefully, but here's the learn version. And you can go through all the different types of arrhythmias, and you can click through it. If you don't like the noise, you can turn off the noise. You can stop it, pause it when you scroll over it, and you can go through all the different arrhythmias and really practice for both your boards and for your exams in NP school. And then once you feel confident, you can go to the game version. And I like to change the settings around, give a lot of time so you don't feel the pressure. And then static EKG, because if you don't do it static, then it keeps going through, and that kind of irritates me because I like to count my boxes and go over all the parts without having to try to catch that EKG strip, right? Because that's how you're going to get it when it's printed on the report, as well as your board. So this way it's just static, and you can practice and take guesses and just click on what you want, and then it'll tell you what the arrhythmia is before moving on to the next one. So it's really fun. I highly recommend it. And I have no personal financial gain for these resources. It's just something that I found useful as an NP student, and I think that you guys would find useful too as you're studying. There's also this book. Again, I get no financial kickbacks for this book, but this is something one of my mentors when I was first entering practice recommended to me. And I know when you're wrapping up NP school and studying for your boards, the last thing you want to do is read one more book. So put this on your wish list, and I guarantee at some point during your first year of clinical practice, you will purchase it and whip it out and read it. And it's a nice read because you can go through it really slowly and go through it piece by piece, and it really breaks it down into simple language, and it'll help you really understand what you're looking at on a 12-lead EKG report and make you feel more confident in how you are treating your patients. Because I know when I was first entering clinical practice, I knew my rhythm strips, but then the 12-lead just overwhelmed me. So this is a really great resource as well, just to help you understand the 12-lead, the lead placements, some of the concepts that we talked about today. And then practice, practice, practice. Do not be afraid to interpret your own 12-lead and then ask somebody, this is what I think it is. What do you see on this 12-lead? Always make sure that you have someone in clinic that you can go to run scenarios by, especially your 12 leads. If you're worried about it, do not rely on the computer to read that 12 lead for you, because oftentimes, and this happened to me when I entered clinical practice, they would ask, oh, did you check the lead placement? Or, let's take this EKG report again. And it's just good to feel good and confident about reading your 12 leads. So don't rely on that computer, because computers are wrong. They can be wrong and they are wrong. So that is my last plug for those resources. Now we'll open it up to a Q&A. You guys did an awesome job participating today. I know this material can sometimes be a little bit dry, but you guys did a really good job getting into the nitty-gritty with me and practicing those practice questions and also answering those tricky questions as we were going through this the arrhythmia strips. So this is your time to ask any questions about what we talked about today, any questions you have about EKG, any questions you have about Archer. I'll leave the slide with you. So what I want to talk about is our Q bank. Definitely making sure you're practicing those questions before your boards is going to be really helpful. We also have a readiness predictor, so you can practice all 1,550 questions and then take the readiness predictor, and it's really accurate in helping determine whether you are ready to sit for your boards exams and how likely it'll be that you'll pass. So our readiness predictor is awesome. We have also a lot of on-demand videos about everything you need to know for your boards exams, about over 13 hours of content, and it's in little bite sizes so you can watch it on your time, but it covers everything. So you can pause it, rewind it, go back to study the things that you don't feel as confident about. And then we have our 3-day live review coming up in September, and that's when we have 3 days of live presentations by instructors and educators like myself and my colleagues. And so that's a really nice opportunity to make sure that you're asking your questions live, and it's really going to cover everything that you need to know for your boards. What I like to tell people is if you can't participate live, at least register for it, because it's a really good deal and you'll have access to all those videos for 30 days after the 3-day live wraps up that Monday after. So it's still a really good deal, and we have a lot of awesome deals coming out that bundle packages together with the live and the Q bank and on-demand videos. So check out the website and see what products work for you. But we at Archer are very big on making sure we provide high-level, affordable resources for you so that you're successful both for your boards and in your clinical practice. So definitely follow us on our socials and sign up for one of these products and see for yourself. But I really appreciate that you guys joined me today. With a few minutes left, I definitely want to make sure I leave time to answer any questions you guys have. So if you need to hop off, that's okay. If you want to stay on and ask your questions, I'm here. There's no rush. So I really appreciate you guys took the time today, and enjoy the rest of your day if you have to hop off. Thank you, Sophia. I really appreciate the participation. And my daughter's name is Sophia with a PH. So that was nice to see today. So Sophie, are you still a student, or are you graduated, getting ready to sit for your boards? Where are you in your NP journey? Oh, she's already hopped off. We have a couple more people still on. Any more questions? I agree with Rachel. Really great work, you guys. This is hard material to go through and sit through. You guys were awesome. And I know you're going to ace it. You're going to do great. All right, you guys, if there are no more questions, I'm going to go ahead and wrap up the webinar. You have our email if you want to contact us directly. We would love to see you at our 3-day live review, and we'll see you at our next webinar. Thanks again for joining today.